We have two chapters on the schedule for this morning. First one is abdominal and genitourinary trauma, or abdominal and genitourinary injuries, I think is the actual title in your book. And then the second is, I think, chapter 31, the orthopedic injuries chapter. These two go together, and something to keep in mind when we're talking about major trauma to any body system and with the risk of internal bleeding. Orthopedic injuries take a back seat in a lot of ways. In a multi-systems trauma patient, you will have a patient, let's just use a car accident, for example. You have two vehicles on a 4-lane, or actually 5-lane city street. There's a turn lane in the middle, and the speed limit on that, let's say, is 50 miles an hour. And you have, this happens, seems like about once a year in Amarillo, even you hear about it, a high-speed head-on collision. 50 miles an hour isn't all that fast, is it? But you take two vehicles going 50-plus miles an hour, because who drives 50 in a 50? Two vehicles going 50-plus miles an hour, and you have a head-on collision because somebody is busy on their phone, somebody's eating a cheeseburger. So people do all kinds of things, reading the newspaper, do all kinds of things while they're trying to drive. I've even heard people get their cell phones out and text and do that kind of stuff. It must be really important text, or you wouldn't risk having a closure speed of 100-plus miles an hour with the head-on collision. Cars today are designed with crumple zones. They're engineered to crash, let's say that. And they're engineered to absorb the energy of a crash to decrease injuries to the occupants. There's no good way. Most people wouldn't be able to afford a car that could be engineered to survive a 100-mile-an-hour impact, because that mechanism of injury of those two cars colliding head-on going 50 miles an hour each, that's like, that'd be similar to driving straight into a reinforced concrete wall at 100 miles per hour. And the vehicles just that we drive, whether you drive the Ford Fiesta, that's a little bitty one, right? Or you drive an $80,000 four-wheel drive pickup, they're not engineered to survive that and have the occupants escape unscathed. This isn't NASCAR. They don't always escape unscathed. But let's say we have that head-on collision, and let's say even one car was going 30 because real busy texting, not paying much attention to driving, going 30 miles an hour, goes in the inside lane, headed eastbound. And you have the turn lane, and then you have westbound that has inside and outside lane. And there's a responsible driver going 50, headed westbound, and the eastbound vehicle at 30 miles an hour, while sending an important text, "K, be there, are you?" Then, and it goes across the turn lane, and you have a head-on collision. And I think last time I checked, 50 plus 30 is 80 miles per hour. So 80 mile an hour closure speed, and bam. And even a restrained passenger or occupant with those deceleration forces high risk of things like, with airbag deployment, high risk of a liver laceration for one. That's one of the biggies. That there's a supporting ligament that will, with those deceleration forces, and remember, the organs inside the body continue in motion until acted upon by an outside force, right? That's good old Newton. He figured that out. I don't think he knew about a ligament that could slice your liver in two, and sure didn't know about texting and head-on collisions, but he did observe that an object in motion remains in motion until acted upon by an outside force. We probably learned that in around the 6th or 7th grade, I think. That's been a lot of years for me, but it was somewhere in there. Could have been 8th. I don't know. They're all the same in my mind now. But the organs continue forward and until acted upon by an outside force. What would that outside force be? That would be reaching the limit of the seatbelt before the little cam roller catches the belt and stops it. Inertia does that. The belt locks down. It is secure, and that stops the body moving forward, but the liver continues moving forward, as do all the other organs. But the liver is sliced by that ligament, and we have some pictures in a little bit, I believe. Hopefully I have those in this slideshow. But that liver, that ligament slices the liver just like you ran it through a bandsaw. And it's more of shredding anyway. But you talk about rapid bleeding. You also probably have some crush injuries to the legs, at least some leg fractures. Let's say in this case, person got off easy. They just have bilateral tib-fib fractures. We didn't even get up into the femurs, where we're going to count each one for at least a 1 liter loss of blood. So we have, let's say they're the open fib fractures, just horrendous looking things. And because of the front end of the vehicle crushing in, and then you have that liver laceration. And we'll stop it there, even though that patient's probably going to have much more trauma than that from the mechanism of injury I described. But the commonality in my scenario is you're going to have a patient, and we're just going to focus on one patient. Obviously, you're going to have a couple of badly injured or dead people, but my patient, the 50-year-old female with bilateral open tib-fib fractures and a partial amputation of the left leg at the side of the open tib-fib, that also has what we call a hot belly, bleeding into the abdomen, severe liver laceration. So like right now in front of you, the progression of hemorrhagic shock is taking place. So, and you also have some horrible looking injuries. Can you see that liver bleeding? No, we don't see blood running out of the abdomen. We don't get it all over our gloves and say, oh, I didn't know the blood felt quite like that. But no, we don't have that. There will be signs that we will see and feel as that liver bleeds, but it's hidden within the abdomen. And we're going to be looking at mangled legs, one of them almost amputated. And if we get focused on those distracting injuries, we can miss that bleeding in the abdomen that is going to kill our patient shortly without surgical intervention. So when you have isolated orthopedic injuries, you have a patient without life threats and with orthopedic injuries, we can focus in on those orthopedic injuries. That can be our priority. If our patient has head trauma, chest trauma, abdominal trauma, they have pelvic fractures, they have a pelvic fracture with signs of internal bleeding in the pelvis, they have bilateral femur fractures. These are all life-threatening injuries. By now, you should know that we find those in our rapid trauma exam that comes somewhere around the primary survey, the way I do it, and I think the way your lab instructors have done it, definitely does not wait down till DCAT BTLS, even though maybe that bleeding in the abdomen, maybe those signs really aren't there quite yet as you do your rapid trauma. So you have a soft, supple abdomen. You do. Your patient has a soft, supple abdomen. As you palpate their abdomen and you don't see major abrasions or contusions, you don't see discoloration. So when you do your rapid trauma, you're feeling pretty good. This patient, I don't think, is bleeding in the abdomen right now. So you make it through, and then if you focus just on splitting up those tib-fib fractures and getting those nice and secure before extrication, you have done your patient a great disservice. With a high energy mechanism of injury, you need to have an index of suspicion, absolutely, of internal bleeding in the abdomen, the signs and symptoms of that. Don't get caught up in distracting injuries, facial lacerations, head lacerations. They bleed like crazy. Obviously, this patient that we're talking now would probably have that. Don't get hung up on, I've got blood dripping off the face and I have bilateral tib-fib fractures on my patient that I have to deal with. Those injuries, they have a much lower priority than injuries that are going to be right now life threats. So what do we do? Let's work through this and figure it out. I'll even tip my hand. We don't blow off those fractures and leave legs flopping around and do all that kind of stuff. We have to be cognizant of those as we extricate this patient onto a backboard. The backboard is a splint. So trick question would be, are we going to splint these tib-fib fractures? Well, if we secure the legs to the backboard, and maybe we even need, if we pull some axial traction, we get those legs in alignment, we secure them to the backboard, we have splinted them. That open tib, those open tib fibs, just throw a trauma dressing over those. It's sterile, throw that over there, secure them to the backboard, and then we need to deal with the life threats and, of course, rapid transport. So all of that makes sense? We good? Okay, we know what trauma is. Abdominal and genitourinary trauma. So this is very complicated. I want you to make sure you catch this, because I don't know if you've heard this before, but the abdomen begins superiorly at the diaphragm and extends down to the pelvis below the umbilicus. That was a joke. You can laugh at that. You knew that. You didn't have to come here to know that, but maybe you called it your belly before. Now in class we're calling it abdomen. Then you hit the street or you're in the ER and they're going to be talking about a hot belly. That's not one that has a nice piercing of the umbilicus and all that stuff. That's we don't have those kinds of hot bellies in medicine. A hot belly is internal bleeding. So I've been talking blunt force trauma with my little scenario. Then of course penetrating trauma. What's the difference? One of them pokes a hole through the skin, the muscle, and penetrates the abdomen. Again, you didn't have to pay $1,000 or $1,500 and come to an EMT class to figure that one out. Evisceration you might not have heard of before. We have penetrating trauma into the abdomen, and you have some structure from the abdomen, some organ that is partially protruding through the abdominal wall, and then an impaled object, it's stabbed there, stuck there, and still in there, right? Okay. Difference in solid and hollow organs, we covered that in the human body chapter. We do see some differences in the presentation and progression of signs and symptoms and the pathophysiology to our patient, whether we have solid organ damage or rupture of a hollow organ. Hit those in a minute. Okay, that's injuries to the external genitalia, not usually life threats. Very painful. Those are highly innervated, very sensitive sensory nerves, and very painful, and causes a high degree of psychological stress in our patient if they have injury to their external genitalia. You have the pain that of course causes, that's a stressor. And then the thought of my external genitalia are severely injured and mangled, and is this ever going to be the same again? We'll talk a little bit about that. And we'll hit a little bit of vaginal bleeding due to trauma. Mostly you're going to see that in sexual assault, but you also see it in, say, more of a, you see that it starts to say more in little girls than little boys. Obviously it's external genitalia vaginal bleeding. That's that could be a fall onto the bar of a bicycle. That could be it could be sexual assault that caused the vaginal bleeding. I hope that you guys never see this, but there are 4-year-old little girls, 2-year-old little girls who are sexually assaulted and penetrated by either by an object or by, usually it would be a man, and penetration and bad tears, and it's a horrible thing to see, and it's hard to work on your patient when you want to break somebody's neck. But we generally don't recommend breaking someone's neck, even though I think a jury might be understanding in that case. We don't do that. We leave it for law enforcement, and they are trained in restraining themselves, and they will want to do the same thing we would, but they will handle the case professionally, as I've seen several times. Okay. Major body cavity, the abdomen, and it extends from the diaphragm to the pelvis. Seems like you've heard that before somewhere. What are the organs? The organs make up the digestive, urinary, and genital urinary systems. It's important to know your anatomy. Why is that? Let's take the abdomen, divide it in. Somehow let's divide it so that we all have a frame of reference. Golly, we could make quadrants out of it and have lines intersecting at the umbilicus and divide that abdomen up, and we'd have a frame of reference. So any other clinician we talk to would know what we're talking about. What do we need to know next? What organs lie where within those quadrants? Right upper quadrant, of course, is liver, and left upper quadrant, the superior aspect, just right up at the edge of the costal arch. Left upper quadrant would be the spleen. So if you palpate the abdomen and you find rigidity in either one of those places, it's time to get up and go. You have a life-threatening emergency. Now the platinum 10's kicked in. We want to be off of that scene in 10 minutes or less, because the golden period, formerly known as the golden hour, is in play. And the quicker our patient receives definitive care for this surgical disease, so surgery is the treatment, the better our patient will do. And that if we can kick tail and end up delivering our patient within the first 30 minutes of that golden period, we are rock stars. You need to do that safely, and you need to do that while still providing good care for your patients. And those are our target marks. Anytime you see that on a test, that's what you need to shoot for. More importantly, when you're in the street taking care of patients, you need to always remember that platinum 10 and always remember that golden period, and that's what the book says. The rest of us call it the golden hour still, I think. Okay, back to those quadrants. Right upper quadrant, liver, gallbladder, duodenum, pancreas. Left upper quadrant, stomach and spleen. Be thinking which ones of all of these are hollow organs and solid organs. Left lower quadrant, descending colon. Left transverse quadrant, right lower quadrant, large intestine, small intestine, and appendix. It looks kind of like that. Right lower quadrant, why would our patient have swelling and inflammation there? One of the biggies would be appendicitis. Oh, that's not trauma. Well, these things don't exist in a vacuum. Could be on the way to the hospital with appendicitis and find themselves in a car crash and now have a lacerated liver and maybe a ruptured appendix that was already inflamed and it was ready to blow, and a little bit of deceleration, and bam, you have a ruptured appendix. You now have bowel contents in the abdomen, plus you have maybe a bleeding liver that you find in the right upper quadrant. So these things can be overwhelming for our patients. What types of shock would we expect to develop from the appendix and with the lacerated liver? Hemorrhagic shock with the lacerated liver. If we have bowel content spilling into that right lower quadrant of the abdomen from a ruptured appendix, now we're looking at, over time, our patient developing septic shock. So two kinds of shock existing simultaneously, or far worse than one kind of shock existing. So that's how we find our patients sometime. And how do we treat that? We treat life threats, and we call ALS if we don't already have ALS there, we call ALS to rendezvous with us on the way, or we call ALS to bring their magic helicopter and spirit our patient away while providing advanced life support to obtain definitive care at the hospital. And let's see. Yeah, we'll hit more of that in treatment. All right. If hollow organs rupture, we can have hydrochloric acid from a ruptured stomach dumped in the abdomen. Let's say bile bile from the biliary system, either in the, could be a partially ruptured pancreas. It could be that all this trauma to the liver has somehow ruptured the gallbladder. I think that would be highly uncommon. Crazy things happen. Bile, remember, is designed to help with the digestion of fatty foods. Hydrochloric acid is made to break down and dissolve things, and if those are spilled in the abdomen, you can expect serious things to happen right now. They will start digesting parts of abdominal organs and attacking abdominal organs, and that is a horrible thing. And then ruptured bladder spills urine into the pelvic cavity, and that pelvic cavity is not designed to have free urine floating around down there, so that does not work well for our patients. Also takes a lot of force, I think, to rupture a urinary bladder, unless it's diseased with cancer or something. And so we might find that in our full secondary head to toe exam of our patient. But if we're looking for other life threats, that ruptured bladder is not going to be a right now kill you emergency normally. So we're going to be looking for other things. I could be wrong on that. Your book could say something different, but we don't talk too much about ruptured bladder in this class. We save that for paramedic school, and it's like 30 minutes of a 4-hour lecture. Okay. Out of these hollow organs listed up here, the stomach and intestines lie within the peritoneal cavity. The abdomen is lined with peritoneum. Those are peritoneal organs. They're inside the peritoneal cavity. The ureters and the bladder those lie outside the peritoneal cavity, as do the kidneys. Kidneys are retroperitoneal organs. They lie outside of the peritoneal cavity. Where do the intestines, where do the small intestines and the colon receive their blood supply? That's the mesenteric arteries, and then the mesenteric veins carry the deoxygenated blood and waste away from the small intestine and the colon. Those arteries originate in the good grief, the interior side of the abdominal muscles and go down into the organs that they supply. Well, that was pretty clumsy. All right, it doesn't matter. We'll keep on moving. I don't think, hopefully I'm not being graded on how smooth my lectures are. Anything we need to talk about here that we haven't already covered? We'll keep moving. Solid organs: liver, spleen, pancreas, and kidneys. Liver, spleen, and kidneys have tremendous blood supply. These are the major filters of the body. They also, the liver and the pancreas are going to have digestive enzymes. The spleen is not, the kidneys won't, but these patients can bleed out extremely quickly. So We have to be good at assessing the abdomen, find that internal bleeding, and treat our patient accordingly. We'll come to that in a few minutes, so I'm not going to forget it. Okay. Injuries to the abdomen, they're open or closed. Does it penetrate the abdominal wall into the peritoneal cavity? Does it not? Blunt trauma. What causes blunt trauma? What mechanisms of injury would give rise to our index of suspicion that our patient has internal bleeding in their abdomen? Steering wheels, bicycle handlebars, motorcycle collisions, falls, all of these things can cause bleeding within the abdomen. Wow, there's something there's a clue. Anybody watch Blue's Clues when they were a kid? There's a clue. My handy dandy notebook. There is a clue. That is ecchymosis. I believe that's right upper quadrant ecchymosis, because I think she has that chest hair coming down there. So I think that's, so what's our index of suspicion going to be as far as internal injuries that accompany that sign that we see? Right upper quadrant, I'm thinking liver, and we need to get on the stick and assess that abdomen, and determine whether that patient has signs and symptoms of hemodynamic compromise. What do I mean by that? Are they bleeding out in their abdomen? Is this patient in compensated shock? Has this patient gone downhill far enough they're in decompensated hemorrhagic shock? So if they're in compensated shock, what do we see with our vital signs? Our first set of vital signs, this patient has a heart rate of 126, respiratory rate of 28, and this patient has a BP of 126 over 84. Well, dang, that blood pressure sounds good. I guess I have time. No, you don't. This patient, they're also pale and diaphoretic. That patient is in compensated hemorrhagic shock. We need to get treatment for them before they are no longer in compensated hemorrhagic shock. We don't want them to progress to decompensated hemorrhagic shock. Pain. Abdominal pain is a strange thing. Abdominal pain quite often is diffuse in nature, meaning it's poorly localized. I can't take one finger and put on the point that hurts the most. It just, my whole abdomen hurts. It's the whole thing, and everywhere you touch it hurts. And you notice that it feels like over time that entire abdomen starts to become more rigid. But I thought we just had trauma to the right upper quadrant. Yes, and as the peritoneum becomes irritated by that free blood or other things within the abdominal cavity, it starts to become more rigid, and that is what that free blood or stomach contents, that the contents of the small intestine or the large intestine, they start to irritate the whole abdomen and the whole peritoneum, and this patient starts to have that diffuse pain, poorly localized. It hurts in my whole abdomen. We do see things like rebound tenderness, which we covered with appendicitis back in 10 or 12 chapters ago now. But so we contrast that with the pain with a fracture, which we'll talk about in about 12 hours because I'm going so slow. But you say you will, I won't be here then. But point tenderness, that is localized pain. right there at the side of that break, that is focused, localized pain. And I can put my finger on where that is, but I'd rather not. That, as contrasted with that diffuse abdominal pain. Okay, liver and spleen refer pain to the shoulder. Liver to the right shoulder, spleen to the left shoulder. If your patient has tearing abdominal pain, just rapid tearing abdominal pain, feels like all of a sudden somebody started just tearing me in two. That is a symptom, because they're describing it. It's a symptom of a dissected aneurysm, and we're talking about the abdomen today. So that would be an abdominal aortic aneurysm that can be caused by trauma. So differences in the quality of the pain, OPQRST, have that tearing pain versus that diffuse pain that I can't put my finger on. So don't miss that tearing pain. That tearing pain is your clue that your patient may have a dissected aneurysm in their abdomen. Which are you going to die from more quickly, liver laceration or dissected abdominal aortic aneurysm? The AAA, abdominal aortic aneurysm, the AAA is going to get them a whole lot faster. If you rupture if that dissection eventually extends through the outer layer of that humongous artery, then it's game over, because they are going to bleed out all of the blood volume that their abdomen will hold from that aortic injury. What mechanisms of injury, with what you know right now, are going to make you think that your patient could have a dissected aneurysm just based on the mechanism of injury? Remember, that would be high-speed T-bone collision, rollovers, and then the rapid rotational mechanisms of injury. So this all comes together. Should be hitting the point in the book where a lot of things are coming together for you. If your test scores are any indication, I think that is in fact the case. Okay. Pain going from the lateral side of the hip, which really we call the flank, right there above the iliac crest, originating there and heading down toward the midline and the groin. We're talking injury to the kidneys or ureters, and that flank pain is just move around. Let's see. Okay. If your patient is supine and you find their greater trochanter, that large prominence of there on the lateral hip, and you move up that midline, up the iliac crest, which is the big arching bone that you're going to follow as you come up, and then you move slightly posteriorly from that midline, that's where you're going to find the kidney, and that's flank pain when it hurts back there. And then if that radiates out from there down toward the midline of the groin, then we're really concerned about kidneys and ureters. Okay, you know what right lower quadrant does. Let's talk pain a little more. Blood and fluid in the peritoneal cavity produces acute pain in the entire abdomen. That's what I was trying to say a minute ago. I apologize. I shouldn't have tried to get ahead. That pain spreads as blood or the contaminants from hollow organs starts to fill the voids in the peritoneal cavity, and then starts to irritate that parietal peritoneum. Remember, the parietal peritoneum lines that abdominal cavity, and when that's irritated, that causes that diffuse pain. And also good old Bloomberg sign, not Bloomberg from in New York. I guess it could have been Dr. Bloomberg, who was from New York. I don't know for sure, but I know this is named after Dr. Bloomberg. You're not expected to remember the name Bloomberg sign, but you need to recognize rebound tenderness is caused from a jarring motion. And we talked a lot about that when we talked about appendicitis that comes from peritonitis, that inflamed peritoneum based on this blood or other bodily fluids, free blood or free bodily fluids within the abdominal cavity, irritating the peritoneum, and then that jarring motion that elicits rebound tenderness or Bloomberg sign. Like we said before, this is poorly localized pain. It just hurts all over my gut. My whole belly hurts. People describe it all kinds of different ways. Some people are really offended when you try to get them to explain the quality of their pain, and then they will want to take a quantity section out of your tail end for asking questions. It's wear steel line shorts as you work the streets, and then when your patients chew on your butt, it won't be such a bad deal. Did I start the recording? I would be embarrassed if I didn't. Sorry. Okay. Wow, that was good, wasn't it? Man, I am on my game today. Everybody should be proud of me. Do I get to drop one grade too? All right. Abdominal distension. You have free blood, fluid, or air in the peritoneal cavity. Free air, how lungs are in the chest, right? Even I learned that this week. Lungs are in the chest. So where is this air going to come from? Anybody ever eat at Taco Bell, and 2 or 3 hours later, you might understand where some air would come from in the abdomen. It could come from ruptured colon, ruptured stomach. It could come from ruptured small intestine, and you're not only going to get solid and liquid contents, but you're also going to get I guess you'd call those farts that ain't happened yet, right? That gas from the digestive tract is loose in the abdomen, and all of that together can cause significant abdominal distension. We're going to be looking for bruising and discoloration, just like that picture I showed you. Distended abdomen. Some of us look like we always have internal bleeding and free air and fluid, and my shirts don't fit like they used to. Okay. Early in the game, and you know this from, I don't know if I'm the only one who ever runs into the corner of a table with their leg, and you think, oh my gosh, there's going to be a giant bruise, and you go to the restroom and you look at your leg, and what do you see? Do you see a giant bruise and horrible discoloration right off the bat? No, you might just see some redness, maybe an abrasion. This blunt trauma to the abdomen is not going to be different than that. So it depends on how quickly you get to them as to what these signs are going to look like. Seatbelts save lives. I can guarantee you that. EMS is far different today than it was when I first hit the streets in early 1982. That's hard to imagine, but I am that old. I have run ambulance calls in a low-top Suburban, and it was the pits. And through deceleration forces or not being properly restrained because of not having the seatbelt on correctly and colliding with other structures inside the passenger compartment of the vehicle, patients can still suffer blunt injuries to abdominal organs while wearing a seatbelt. Wearing it correctly makes a big difference. I don't see as many people now driving with the shoulder harness part of their seatbelt tucked behind their backs. That was the big deal back, especially when seatbelt law first passed. They had their lap belt across there, but they didn't want to wrinkle their clothes or whatever the thing was. They'd put that shoulder harness behind them, and you just don't see that often. I know it still happens, but so could be that manner of wearing the seatbelt improperly. It could be wearing the lap belt too high, particularly with the pregnant woman. If that lap belt goes right across that her uterus, that gets more and more distended all the time, that can cause internal injuries, including uterine rupture, which we'll talk about next week. Can result in a ruptured urinary bladder. True confession time. Based on my experiences in EMS, I don't ever start driving someplace, even if I'm driving 10 minutes, 5 minutes. If I think I need to pee, I go pee, because I want to have an empty bladder if I'm involved in a traffic accident, because I do not want to have a ruptured urinary bladder. So that's a word to the wise. Okay. There's seatbelt positioning, open injuries. You have a foreign object enter the abdomen. We call these penetrating injuries, stab wounds, gunshot wounds. Not every abdominal wound penetrates through the abdominal cavity, through the muscle, through the peritoneum, and into the abdominal cavity. We don't, and I just talk about something that still kind of sends cold chills up my spine when I think about it. You will see doctors quite often throw a sterile glove on when somebody has a wound to the abdomen, and they'll take a finger and they will slowly and gently, based on education and experience, probe that wound to see if it penetrated in through the peritoneum and into the peritoneal cavity. I have seen years and years ago, I have seen a paramedic or two do that when I was looking away and didn't see him start to do it, and I'm involved in my part of patient care, and look up and they're probing a wound. We do not do that. I don't care if you're the most hotshot paramedic on the streets. We do not do that. We can cause further injury to our patient without the ability to provide immediate surgical intervention. So do not do that. And if you have a partner who starts to do that, you're an EMT and they're a very experienced paramedic, you still have an obligation to say, hey, wait, what are you doing? If they persist, they persist, and you're going to have to report that. And that's a tough one to have a lower level of training, and you see somebody do something that you know is wrong. It lies on your shoulders too, unless you report it. So don't be probing any wounds, and don't let anybody else do it. Low velocity, knives, edged weapons, rebar. Rebar comes up a lot because you will see a lot of construction site injuries, and you will see people trip and fall over a 2x4 that they didn't see a minute ago, or wasn't there a minute ago. We're building a dang house. Things change all the time really fast because time is money. And trip over a 2x4 that was just laid out for some construction, land on rebar that penetrates the left upper quadrant of the abdomen, and then it exits, seems like at about the level of the xiphoid process, but it's posteriorly, and it exits right around, just let's say 5 centimeters left lateral of the midline in the back of the middle of the spine. And we have an abdominal penetrating wound. We likely have a penetrating chest wound that left upper quadrant that could involve the stomach, that could involve the spleen, and then where that exited, there's a chance it, depending, it kind of have to, in your mind, draw an imaginary line between entrance and exit. But man, I need to check and make sure that hasn't affected the heart. Does my patient have a pneumothorax that's going to start to develop on me? So in your assessment, knowing that you can't always determine the exact path of a penetrating object, you need to try to get as close as you can between entrance and exit and figure out what might be involved. What do we call that? From that mechanism of injury, that's figuring out what might be going on is index of suspicion, right? Okay, medium velocity, small caliber handguns. Man, back in the day, a 25 automatic was the weapon of choice. Now it seems to be a 9mm, which is more on the high velocity side, of course, but I ran lots of killings and almost killings with 25 autos, small, easy to conceal. And shotguns, I'm going to treat that like it's a high velocity, but you don't have the same degree of cavitation with those pellets striking the body. Let's go on and talk about high and medium velocity. What do we expect that's different with high velocity than with medium velocity? With high velocity, you have, with medium and high, low, medium, and high, you have permanent cavity, which is the path of the projectile, and we'll even, let's call for now, call a knife blade, rebar, whatever. We're going to call that a projectile. You have a permanent cavity caused by that. What we're talking about here is a temporary cavity, sometimes called a wound channel. It's caused by, well, we talked about this in the trauma overview, but that pressure wave moving through with that projectile, spreading tissue apart, and then it comes back together. But what happens as that energy spreads the tissue apart, you have tearing of blood vessels and nerves, and that can produce tremendous bleeding. So the higher velocity of the projectile, the larger the cavity it produces, the larger the temporary cavity that is produced, the higher risk of injury that your patient suffers. So low velocity, our primary thing there is going to be the direct damage to organs, not that indirect tearing from the energy wave moving through that accompanies that bullet. Come back and take my advanced trauma class, and I'll have some cool videos on cavitation and all that cool stuff. Okay. If rule of thumb, I don't like the word assume, because I was taught if you break that down, if you assume anything in medicine, you have an ass on the left and me on the right, and maybe you're my partner and I drag you along with me, so you're in the middle, and I don't want to do anything that makes an ass of you and me, because it affects our patient. So we're not going to do that. So anytime I see that word, I kind of sends a cold shiver up my. I'm getting lots of cold shivers today. This is bad. This is bad, folks. Okay. Any injury below the xiphoid process, we're going to assume that has affected the thoracic and peritoneal cavities, and we're going to assess accordingly. Evisceration, you have bowel protruding through the peritoneum and to the outside. Have some pictures of that in a few minutes that will help, I think. It blows your mind the first time you see it, because you say, well, yep, that looks kind of like what was in the book. Don't try to poke it back in. Leave it hanging out. We do have a life-threatening emergency. We have started the clock on our platinum 10 and our golden period. So we are not going to stay and play, and our secondary survey is going to be en route to the hospital, right? Yes, everybody shake your head, yes. Perform a visual assessment. We're not going to try to pull clothing out of that. Maybe there's a stab wound and it pushed some of a cotton shirt down into the peritoneal cavity on the way in, and now you have eviscerated bowel that's all around that cloth. Cut around it, leave the cloth there, put a sterile dressing over that, and then put an occlusive dressing over that, because we need to keep any air out of any external air out of the abdominal cavity. We don't, if there's a damaged vessel in there, we don't want to create an air embolism by introducing that external air into one of the large vessels of the abdomen. And don't ever try to pull clothes out. Just cut around. Their clothes are ruined already. Clothes are secondary in our world. It's not clothing optional day, it's just clothes are secondary. Okay, let's take 5 and come back and do signs and symptoms, and we'll pick up a little more speed. Continuing with open abdominal injury, signs and symptoms: pain, tachycardia. Why is there tachycardia there? They're headed into compensated shock. So have adrenaline being released, and that's going to increase the heart rate, and then we're going to, so the heart is trying to compensate for that loss of volume by increasing the rate to try to maintain cardiac output. Stroke volume's gone down, and the body's going to try to maintain perfusion by increasing the heart rate to maintain cardiac output. And then you know that mental status starts to suffer in our patients who are in shock. That they'll be cool, pale, diaphoretic, distended abdomen. Patients can have both closed and open injuries. So when we see the signs of the blunt injury, that discoloration, or later the ecchymosis, and then we need to immediately in our minds determine what structures lie beneath that, and then assess really well to determine what might be injured, what might be bleeding. Right upper quadrant liver, left upper quadrant spleen or stomach, and then flank is kidney, as I stumbled through trying to describe earlier. Cullen's sign, if you see, it's called periumbilical bruising. That circular bruising around the umbilicus is called Cullen's sign. That develops later in the process. That's just blood, that free blood in the abdomen that makes its way through and starts to cause that bruised appearance around the umbilicus. Gray-Turner sign is, I think we have that in a minute. Never mind. Don't let me get ahead. Okay. Hollow organ injuries have delay in the onset of signs and symptoms because the signs and symptoms that we see and the developing pathophysiology within our patients is due to the irritation and infection and maybe depending on which hollow organ, even some digestion and breakdown of tissues within the abdomen due to the bile or that hydrochloric acid from the stomach leaking into the peritoneal cavity, and it wreaks havoc, but it doesn't do it immediately. Hollow organs, sometimes patients will tell you they felt a pop, or they'll tell you they heard a pop. It's not an auditory pop, but in their minds it is. They heard a pop, and then over time their belly started hurting a bunch. That's talked about free air already. That free air in the abdomen, if you have a tear that involves any of the mesenteric vasculature, some of that methane gas from the digestive tract could make its way into a mesenteric artery or vein and cause an air embolism eventually, or it can just cause a localized infarction. Again, that would be an embolism because of the air. What is the infarction? That's a blockage, right? So that's an air blockage within, and let's say it moved into a mesenteric vein. We got some of that free methane in the abdomen that's coming out of the colon, and that's pulled into mesenteric vein, and that air blocks that mesenteric vein and nothing else can move through it. So that's a major problem. We can't fix it. We need a surgeon to find it and fix it. Or how are they going to fix it? In all likelihood, with the bowel resection, they cut out a piece of the bowel. And when they resect the bowel, I watched one of these, and it was really interesting because I always wondered, how in the heck do they put those little mesenteric arteries and veins back together? They don't. They just take they cut that section out, and they put the two good ends together, and then the existing mesenteric arteries and veins are what work to perfuse that piece of intestine. So sometimes I guess my mind wants to make surgery more complicated than it is. But liver we've talked about over and over and over. So if you have a patient, you don't have to have a patient necessarily with abdominal trauma to cause a liver laceration and cause the liver to bleed. It could be injury to like in that area around the costal arch. Does everybody know what I'm talking about? So find your xiphoid process at the terminating portion of your sternum. So right there by your abdomen, you find your xiphoid process, and then that costal arch, that arch of cartilage and rib that moves around laterally from there. The liver is tucked up under those ribs for protection. So it could be fractured ribs in that lower area of the thoracic cavity that causes the damage to the liver. So anything that's in the inferior rib cage in the area of that costal arch where the liver sits, or in the right upper quadrant, we need to be thinking liver and looking for signs and symptoms of bleeding from the liver. Okay. Spleen and pancreas are highly vascular, heavy bleeding if those are involved. So what kind of mechanism of injuries would we see that might cause a problem with this thing we're calling a spleen? MVCs, steering wheel trauma. I'm thinking steering wheel trauma goes with MVCs, unless a hitman beats someone to death with the steering wheel off of a 43 Buick. I don't think there's a 43 Buick because that was during the war. So either had to be a 42 or a 46, but we'll make it a 46. So hitman beats somebody to death with the steering wheel of a 46 Buick, then it wouldn't be an MVC. But I'm thinking that a little redundancy there that I made too big a deal of, but it's just one of those things that jumped out in my head. Falls from heights, bicycle and motorcycle accidents involving striking the handlebars, not uncommon at all. You know where the diaphragm is, divides the chest cavity from the abdominal cavity. It is possible to have a diaphragmatic tear and end up with loops of bowel up into the chest cavity. And those are, you have an abdominal injury with a sudden onset of dyspnea that accompanied it, because you have loops of bowel up in the thoracic cavity, and that's interfering with the expansion and contraction of the lung, which interferes with perfusion and oxygenation. So I have heard clinicians say that I heard bowel sounds when I listened for breath sounds. I have had a few patients with diaphragmatic tears, ruptures from a high-speed mechanism of injury, and I know that that's what they had because I later saw the x-rays, and that I was still in the ER when they did a chest x-ray, and walked back in the room because you always want to see what's happening with your patient after you're done with paperwork. And there's a chest x-ray which has loops of bowel up in the chest x-ray. It's going to be up on the left side is where you're going to normally see that tear and see the loops of bowel. But I never heard bowel sounds in the chest on those patients. And very experienced trauma surgeons told me that it's rare that you hear that. Also, it may just be that you don't have the bowel sounds because you have the diaphragm constricting around that loop of bowel after it's up there, and you just don't. It's just frozen and nothing's happening in that loop of bowel. But I don't know. I won't call my friends liars. I'm just suspicious of their report. Maybe they saw those x-rays like I did, and then I must have heard bowel sounds up there. I don't know. It doesn't matter. Know that is a high takes what am I trying to say? It either takes sharp penetrating trauma that the path of the weapon goes from the peritoneal cavity up into the thoracic cavity, and then a loop of bowel winds up there, or there's sudden deceleration forces that somehow tears the diaphragm. That is a tough muscle, but there are cases where the diaphragm is torn and you get some bowel up there. So if you see a question with abdominal trauma and just a sudden onset of dyspnea, then be looking in the answer to see if there's anything there involving a diaphragmatic tear with part of the stomach or a loop of bowel up there in the thoracic cavity. Not something we can really diagnose in the field very well. Our only clue would be that sudden onset of dyspnea. Okay, kidneys, tremendous blood supply. That's a major filter. That's one of the big places that our bodies get rid of toxins and filter toxins out of our blood and to our body. Things that are therapeutic to us, like medications, are still viewed as toxins by the body and filtered by the blood and then discharged as urine. You knew that before you got here too, didn't you? If you have a patient with abdominal trauma and you trauma strip them down to their underwear, maybe we're nice today, we leave the underwear because we didn't see any need to check under the hood, I guess you could say. So I didn't suspect genitourinary trauma. So even though I palpated that lower abdomen and I felt for any rigidity, I looked for distension, I did all the right stuff. Maybe I didn't see a need to go ahead and cut the underwear off. But then I notice as I'm working through DCAT BTLS, there's a spot of bright red blood on the underwear, or patient takes a helmet to the lower abdomen in a football game, and then a few hours, or I mean, not to the lower abdomen, to the flank. The patient is, bam, they get tackled, they get nailed in the flank, and shower out, get home from the game, not feeling too good, get up to go to the restroom, or wake up and look down and there's a spot of bright red blood on their underwear. You will make that call if you work in Texas or Oklahoma, where football is king. You will run that call eventually, where a young man, or now a young woman, gets drilled in the flank and starts to have bleeding in the kidney. They start to have hematuria, and they wind up with a spot of blood on their underwear. So let's extend that a little further. Things that the slideshow doesn't have. Blood in the urine normally causes dysuria. It causes burning at the urinary meatus, which is the opening to the outside. So that would be at in the glans penis area of a male, and at the urethral opening in a female. That blood causes burning, painful urination, and that may be what causes this person to seek medical care. But if your patient has flank trauma and they have blood in their underwear, then that is significant trauma to that kidney. Kidney can bleed rapidly. Oddly enough, they usually call it a kidney fracture. When the kidney tears, the parenchyma of the kidney tears. I always associate fractures with bones. So when they tell me somebody had a fractured spleen or a fractured kidney, that kind of messes with my head. Maybe that's why they do it. Abdominal injuries can be occult injuries. I'm not talking devil worshipers. I'm talking things that are hard for us to see or find because they happen on the inside, especially with blunt force trauma. And we have to be good detectives and engage everything we've learned about patient assessment as we work through DCAT BTLS, and as we work through, prior to that, our rapid trauma assessment, to start to find palpation on our physical exam that elicits pain. Where is that pain? What's the pain like? Is it diffuse or is it localized? Do I see discoloration? Do I see abdominal distension? Did my patient tell me that they felt a tearing pain right after right after that head-on collision. Man, that's how we find these things, and we have to. That's why we've taught you this patient assessment algorithm. It's why I wanted you working with that the whole semester and mastering that, so that when we got down here to trauma, it would make sense and this stuff starts to click. Not only what the book says I do, but through lab, we're not Ricky Bobby and Talladega Nights. We know what to do with our hands. Put them on our patients in an organized clinical fashion, of course, to determine what might be going on inside that abdomen. Take care of yourself. You're always going to don your appropriate PPE. Scene has to be safe. None of that has changed. If I see anything different here, I'll slow down, but we're just working through this. We're working through the algorithm, right? It's just there over and over in every chapter. Here, we're talking mechanism of injury. We also need to inquire about any underlying illness. Maybe it was chest pain that caused them to want to drive themselves to the hospital at 58 miles an hour in a 30-mile zone when they ran into that telephone pole. But we could have nature of illness going on along with, so we could have trauma assessment and medical assessment happen at the same time. Oh my gosh, what do? You do what you always do. You ask questions and you poke and prod and you engage all this stuff you've learned over the course of this semester, and you'll be amazed at what you can do. All you need is a little more confidence. Dumbo could always fly, but he didn't know it till he had that magic feather in his trunk. Well, we're giving you the magic feather, and you get out there and get some experience, and you'll fly, and you'll find yourself, I guess if I go with Dumbo, you'll find yourself with a hangover in a tree with a talking rat, so be careful. All right. Remember spinal precautions. Look at the MOI. You are the person who sees that scene and then conveys that scene to the ER doc. You are that one person who can tell how that vehicle was wrapped around the telephone pole and or those two cars were crushed together, and that's have your partner whip out their phone, take some pictures of the cars. If there's somebody there who can do that and it doesn't compromise patient care, because not only can you describe that mechanism of injury, you can show them in the ER, there's a car, there's a car, there's a car. Here's the inside of the car. That's, if it's not going to compromise patient care, take that expensive thing on your hip and put it to some positive good without violating HIPAA. Okay. Inspect the penetration. Do not touch the penetration. Your rapid trauma, which they call rapid scan, you're looking for life threats. You find them, you fix them, and you don't move on until you've managed them, right? Okay. General impression. Are they FTD, fixing to die? Not in the South. I don't think they use that acronym. They don't know what fixing is. They think you're repairing something. Are they FTD, or do they have minor injuries and they're okay? That is general impression. You know that by now. Biggie is going to be AVPU. What is their mental status? That tells us a lot, right? If they've suffered blunt force trauma and they only respond to painful stimuli, and bystanders tell you that they were conscious, alert, appropriate, well-oriented, all the things we call that, prior to the accident, something major has happened. Is it head trauma? Is it hypoxia? Is it poor perfusion secondary to hemorrhagic shock? What is causing this change in their mental status on the AVPU scale? Okay, I'm going to just go straight through this. You guys know, have suction available. I will add that. You know how to manage an airway by now. You know how to provide oxygen, when to do it. You know when to assist ventilations. All those things you guys are doing great with. So if anybody from somewhere else watches this lecture, they're going to miss some stuff because I know what you've done in lab. I know what you've done on exams, and I can't teach the whole course every time we do a lecture. But spinal immobilization, if indicated, keep suction handy. Abdominal injuries can cause nausea and vomiting, and you don't want your patient to aspirate vomitus or emesis, whichever you want to call it, and then compromise their respiratory status because we didn't have suction ready to go and we didn't stay on top of pulling that backboard up on the side and getting that funko out of their mouths. Let's don't goof around with the nasal cannula with somebody with major abdominal trauma. Let's go straight to that non-rebreather mask at 15 liters per minute. Be aggressive in your treatment of your patient with signs and symptoms of internal bleeding and signs and symptoms of shock. If they're tachycardic, their skin color is pale, and cool to the touch, then, but they still have a good blood pressure, we're going to treat them as if they're in hemorrhagic shock. So how do we do that? Rule number one, this ain't in your book. This is another Southern term, I think. We ain't going to jack around on the scene, are we? We know the platinum 10 is in play while providing good assessment, initial assessment and stabilization of our patient. We're in a race with the clock, and we want to beat that 10 minutes if at all possible. Could contact ALS to rendezvous with you on the way to the hospital. Here's one that I don't see done in the streets enough, and it needs to be done. It's July in Amarillo, Texas. Last week we had a 108-degree day. So that's hot, right? It's hot where I come from. And if I had my patient that we started this lecture with, who has mangled legs but has a hot belly, probably have a lacerated liver that we're dealing with, I'm going to be hot. I'm going to be sweating when I get them extricated and packaged in the back of my ambulance for transport, and I'm going to turn the AC on so I can be comfortable, right? Wrong. I'm going to turn the dadgum heater on when it's 108 degrees outside, because one of the ways that EMTs treat hemorrhagic shock is to do everything we can to help the body manage blood loss. Well, I can't hold direct pressure on a liver and make it stop bleeding. I can't put a tourniquet on a liver and make it stop bleeding. What can I do to help that patient not bleed? We can do our part in managing the coagulation cascade, and one of the big killers of trauma patients is hypothermia, and that interferes with that coagulation cascade. We spend a lot of time on that in the advanced trauma class. Trust me that it's correct, that hypothermia interrupts the coagulation cascade, and there's including clotting factors, the whole 9 yards. It's like 15 sequential chemical steps in that coagulation cascade, and hypothermia short circuits that, and your patient won't coagulate. They won't try to clot and stop that bleeding. So we can if we keep them hot and we have blankets under them on the backboard and we have blankets over them and we have that heater on, we can help with the coagulation / clotting cascade, and we may be able to help slow that hemorrhage until our patient receives definitive care. So you may have a battle of the thermostat in the back of that ambulance with whoever wants to be cool, but you're an educated, quality clinician, and you know you need to keep your trauma patients warm. So we're going to do that with blankets and a heater, right? Right. Okay. Abdominal injuries that have signs and symptoms of life threats necessitate rapid transport. Whether that's ground transport or air transport, it's rapid transport. We may not get past life threats to get down to getting a sample history. Our patient may be unconscious, unresponsive, without a medical alert tag. They don't have their prescription bag with them. We have no way of determining a medical history. We might not even get down to sample an OPQRST. We're dealing with life threats. We're going to do any history other than what we might quickly get from bystanders, what we might determine from the mechanism of injury. Bystanders may be our only hope of getting any kind of history. As we investigate the chief complaint, we're going to identify signs and symptoms and pertinent negatives. Again, what the heck's a pertinent negative? Signs: patient has a large contusion to the right upper quadrant, and let's leave out a symptom right now. Maybe our patient feels slightly nauseated. Have a large contusion to the right upper quadrant. Patient states they have some nausea and some pain. Then we palpate the abdomen and it's soft and supple in all quadrants. That's a pertinent negative, that abdomen is soft and non-tender in the right upper quadrant, while I visualize a large hematoma in the right upper quadrant, and the patient states has dizziness and nausea and don't let me die. I'm going to die. Don't let me die. But that abdomen is still soft when we palpate it. So that's the pertinent negative out of that. Okay, patients will want to, because blood and bodily fluids irritate the peritoneum throughout. It starts in a small area and then it irritates the peritoneum throughout the abdomen. These patients don't want to lie supine with their legs flat. They want to pull their knees up. So what is that? That's a sign to us that the peritoneum is being irritated by something, because the patient, they pull their knees up. They don't want to have their legs flat because it hurts to stretch that peritoneum. If we can get a sample history, we get it. If we can get OPQRST, we're going to get it. Nausea, vomiting, diarrhea. Depending on the proximity of your interaction with the patient to the injury, we might not know about diarrhea. In the field, we might know if they have diarrhea, because we're going to have diarrhea. It just isn't going to be coming from us. We're going to have diarrhea all around us. So it will happen. Get ready for it. It's okay. It washes off. Okay. If our patient encounter is removed in proximity from the occurrence of the event, we need to ask them if they've had any bowel movements. If so, were they solid or were they liquid? What was the color of it? Was there black Was it a black tarry stool? That's melena. That indicates bleeding. Was it bright red? That would indicate damage probably to the rectosigmoid colon, or the rectum. That's that bright red blood. And then urine. Did they notice any blood in their urine? Did they have painful urination? How often have they been urinating since the event? That will help you in your determination as to any internal bleeding and what is bleeding. Is it the small bowel? Is it the colon, or is it somewhere in the urinary tract? I guess I said, and with if you have injury to a ureter or injury somewhere in the urethra, that could be some bright red blood, and then other blood. If it's up in the kidney, that may just cause the urine to have a real concentrated look. What I mean is it's more orange and moving maybe toward a golden brown kind of color. So it depends on what's injured and how quickly it's bleeding. Because you can see bright red blood from the injury to a kidney itself. So sometimes they only find that blood when they take some urine and put on a slide and look under a microscope and see red blood cells there. Okay. You may never get to your secondary assessment. You know that by now. We're going to do all the same things we always do, and then we're going to add that unless our patient has a spinal injury and we have full spinal immobilization on them, meaning that their C-spine's immobilized and they're on a long spine board, they're going to want to have their knees up. Again, that tension, relieving that tension in the abdomen takes some of the stress off of the peritoneum, and it can decrease the pain. Even with a suspected spine injury, as long as your patient is secured to the backboard well, I still think you could put some blankets behind their knees and take some of that tension off and relieve some of that pain. But you can't compromise having them secured to that board, because if you suspect a spinal injury, they have to be secured to that board. If they have nausea and vomiting, they sure have to be secured to that board, because you have to be able to turn the board up, have them on their side, and pack blankets behind that long spine board so that you decrease the chance of aspiration. None of that's new stuff, right? That's good to have stuff that we've done over and over, right? Examine the abdomen, try to determine by the entrance and exit wound what the rough path of the projectile was. Was it, and then we're going to utilize DCAT BTLS to look for deformity, crepitus, abrasions, punctures and penetrations, burns. I just spaced out, guys. Somebody help me. Lacerations and swelling. Tenderness. Golly. I did that on purpose. That was a teaching tool. I didn't have a brain fart or anything right now. Good grief. Tenderness. That's a big part of, we've been talking about that for almost 2 hours now. Come on, buddy. Golly. Okay. We do the same things that we've done the whole semester there. Thanks for helping me out and getting me off high center. I just needed a nudge to get my wheels engaged, but I got stuck over a really simple thing. Okay. We're going to start palpating in the quadrant furthest away from the quadrant exhibiting signs of pain and injury. Work back to going where the pain is. That's different from that abdominal assessment that we did in a medical case where we thought that our patient might have appendicitis, we didn't palpate that right lower quadrant, did we? We skipped that because we were looking for rebound tenderness, and we can find that in one of the other quadrants besides that right lower quadrant, and we didn't want to rupture that appendix. In this abdominal assessment with trauma, we got to palpate the entire abdomen. Finish up with the one that appears to be hurt the worst. How about that? Ask questions about any radiating pain. That is a really important question. Blood from the spleen or from the liver, you have to have, let's just go with the liver on this one. The liver is in a capsule. There is not room for expansion in there. So bleeding from the liver, once it extends enough and you have enough blood volume there, that starts to put pressure on nerves, and that's what causes the radiation. So that the radiating pain into the shoulder is going to be a sign to you that the liver is pushing against that capsule that it sits in, and that tells you that there's a significant amount of bleeding in there. All right. Palpate the kidney area for tenderness. We need to always do that. What is your one shot at visualizing all of that? That's if you have a patient who is going to be secured to a long spine board, that's when you log roll them onto that spine board, right? So we have to trauma strip them in the back when we roll them up. So we're going to have to provide good inline cervical spine stabilization, and tell our team members in advance, I've got to assess this back, so we're going to roll them up. You're going to have to hold it for give me a good 30 seconds or so I can assess this back, and then you're going to have to assess that back for decap BTLS. And remember, there's tenderness is the T in that, guys, by the way. That's a tenderness, bruising, swelling, other signs of trauma on the back, including those flanks on either side for the kidney. Vital signs, yes, let's do those, and let's get SpO2. And if you have it available, Untitled CO2, because that gives you a better picture of perfusion than SpO2. We've learned that if you're on a BLS truck, you're probably in a place that either you have a tiered system so that ALS is already on their way and you're getting initial assessment done, or if you're in a remote area, say you're a volunteer on an ambulance in the middle of the desert in New Mexico, it just could be that your service can't afford Untitled CO2. So SpO2, and then your patient's perfusion. We're going to assess that with that AVPU scale and with our Glasgow Coma scale to determine we'll count those as vital signs to determine the perfusion of our patient. Don't get down to focusing on an injury to a certain area of the abdomen until you've done a good head to toe on your patient. We call that tunnel vision, and tunnel vision causes patients to get dead, and we don't like that. So you have to eventually, you're going to eliminate all kinds of things. You're going to rule out any problems with the right arm and the left leg and the everything after that head to toe, and then you can do your focused assessment on the involved portion of the abdomen and the structures that lie within that area, but don't get there without doing a full patient assessment. Communication and documentation, same as always. But remember, you're the eyes and ears. You are the one to convey information about the mechanism of injury. Other patients who were dead on the scene, remember that if we have someone who appears to be non-critical, but they were in a patient compartment with someone who was deceased on the scene, our patient became critical based on that mechanism of injury. And the amount of, then you add to that the amount of intrusion into the passenger compartment, all of those mechanism of injury things you need to convey to hospital staff and document. Closed abdominal injuries, let's see. Of course, rapid transport where indicated. Want to take those with the trauma to those, take those to a trauma center with the surgeon. They may be stabilized and transported by helicopter to a level 1 trauma center for another surgeon. But if we take them to a dermatology clinic, we've messed up, right? Okay. Place them in the position of comfort as long as that doesn't compromise spinal immobilization. Get that high flow oxygen on them. Be ready to go to your positive pressure ventilation to bag assist their ventilations if they have signs of poor perfusion. Okay, things that we're going to look for: severe bruising to the abdominal wall, trauma in the area that would give rise to an index of suspicion of liver laceration, spleen laceration, all the things that we just talked about. That's what we're looking for with blunt force trauma. Log roll them on a spine board, protect the spine, monitor vital signs, rapid transport, treat for shock. Open abdominal injuries, we're going to treat the same, except for we need to deal with the penetration, right? Just because there's a slight amount of blood in the area around the entrance wound doesn't mean that there's not massive internal bleeding. So we have to do a complete assessment of our patient to determine signs and symptoms of the internal bleeding. We are going to put a dry, sterile dressing over open wounds. This is a treatment change from the old way. The old way, we put a moist, sterile dressing. So we put the dressing over the penetrating abdominal injury, and then we took sterile saline and soaked that dressing because we didn't want that dressing to stick to protruding. We didn't want that anyway. We didn't want the dressing to stick to our patient. Let's leave it there. When they're ready to take that dressing off, they will irrigate it, get it wet, they'll loosen it up. We're going to put a dry, sterile dressing to cover these abdominal wounds. If we have penetrating trauma to the abdomen, I want you to slide in another bullet point in your notes here, and we need to put an occlusive dressing over that dry, sterile dressing, secure that on all 4 sides with tape. Then we could put a bandage around that. What we're normally going to do is put the dry, sterile dressing on. We're going to tape that down. Then we're going to take our occlusive dressing and put over that dry, sterile dressing, and we're going to tape it down on all 4 sides and make sure it sticks. If there's a lot of blood and vomit and all kinds and radiator fluid, then it may be a little harder to make it stick. Make sure you use enough tape to get a good seal, because we don't want our patient to die from an air embolism before they can be treated by a surgeon for their evisceration. Here is some small bowel hanging out of this poor fellow's abdomen. Don't try to poke it back in. keep the organs moist and warm. Well, how the heck we do that? We don't have heating pad on the back of the truck. Keep a blanket over your patient, keep it warm in the back of your truck like you're going to do anyway. Moist sterile dressing, occlusive dressing. We can secure that dressing with the bandage. Pretty doesn't count here. Sealing that abdomen, that occlusive dressing on that abdomen is what counts. Okay, genitourinary trauma. We've talked about kidneys quite a bit already. You know that male genitalia are on the outside. Female are on the inside, looks kind of like that and that. Kidneys are very well protected. They're a retroperitoneal organ, but they are very well protected. Penetrating trauma or forceful blunt trauma is what will be involved in injuring a kidney. The forceful blow, that could be being tackled in football, blocked in the back in football, kicked in the back or kicked in the flank, I mean, in martial arts, getting cross-checked into the glass in hockey. I've been hit with a baseball in the area of my left kidney, and it didn't cause any internal damage, but maybe the fastball wasn't fast enough. So that can happen. Things that are going to give us, that are going to raise an index of suspicion that our patient has a kidney injury. So the signs that we're going to go with, and I'll tell you when we find a symptom if we do. Abrasion, laceration, contusion of the flank. We know where the flank is now. Penetrating wound to the flank or upper abdomen. Fracture on either side of the lower rib cage, lower thoracic or upper lumbar vertebra, and then hematoma in the flank region. If our patient describes burning urination or blood in their urine, then we're gonna suspect that our patient has a kidney injury. We're gonna treat them for shock. We can't fix the kidney. All we can do is treat them for shock until a surgeon can get to them, or a type of surgeon called a urologist. They're amazing folks, and they will, and general surgeons also deal with kidneys, but together they'll do a good job of taking care of them. We just have to get a live patient to them so they have something to work with. Ruptured urinary bladder, I've described how they can happen: sudden deceleration, misuse of a lap belt, the third trimester mainly of pregnancy. Bladder injuries really increase just because of changing pelvic anatomy. Could be a bone fragment from a fractured pelvis. Remember, we told you when you're assessing a pelvis that you put a hand on each of the greater trochanters and you kind of push inward and upward at the same time, and if that elicits pain, then we don't push anymore. Here's why we don't push anymore. If this portion of the ilium or the pelvic bone fractures, those fractured bone ends can puncture the urinary bladder. So once you find that pain in the pelvis, we call that an unstable pelvis then, and we're not going to continue to squeeze on that. We're going to treat that patient for a pelvic fracture, and we're going to learn how to do that here in about 45 minutes probably. External genitalia injuries, and then we're about to wrap up this chapter. They're soft tissue wounds. Manage the bleeding. They're soft tissue wounds that will really get your patient's attention. Whether it's a little boy who's Mom was bathing him and his little brother. Here's a scenario. Little 4-year-old, mom finishes bathing him first, and she's focusing now on the 2-year-old in the bathtub there with the 4-year-old boy, and dries him off, getting him out of the bathtub, and says, "Oh, run and get your underwear out of your drawer and put them on." And he's proud that he knows how to do these things now. And he takes off and he opens the drawer and he gets his little underwear out, and he uses the front of his legs and pelvic area to close that drawer. And through some freak, his penis is slammed in that drawer when he closes it, and that causes internal bleeding in his penis, and it's very painful. And that there's only so much room for that to swell as that bleeds. That will eventually restrict circulation, can cause a kid to have an amputated penis and end up with a suprapubic catheter to drain the urinary bladder for the rest of his life. So ran that call, very painful. I also thought I was going to have to sedate mom because it was, in her mind, it was all her fault. It was as if she intentionally did that to that little boy because she forgot to get his underwear. And you have to, while treating your patient, console the mom or whoever it is. Maybe it's an adult and they're in a hurry at the urinal and they zip their penis up in their zipper and they can't get it back out, and that's how we come to meet them. That bleeds some. It's highly innervated. It hurts, and we're supposed to be the ones to fix it. Sometimes we can't get that zipper back down if it involves too much of the zipper, or if there's too much of the skin from the shaft of the penis zipped up in the zipper. Our patient has a problem we can't fix. So what can we do? Manage bleeding. Call for ALS. They can give some pain meds that will help with the stress our patient's feeling from the situation. It'll help with the pain. Things will get better with some pain medicine. Female genitalia injuries. It is possible to fracture a penis during intercourse also. There's a chance someday you might run that call. That's a painful thing, causes considerable swelling. Put ice on it, call ALS to give them some pain meds and deal with the pain and get them onto the hospital. If ALS isn't available, all you have available is ice and oxygen. The ice goes on the damaged area, the oxygen goes up there for the airway, just so you don't get that mixed up. That was funny too. You can write that down. Buddy said something was funny, at least to him. Internal female injuries, traumatic injuries. We don't usually see the uterus, ovaries, fallopian tubes injured except for when they're greatly enlarged during pregnancy. Uterus starts to push up out of the pelvis, and it's susceptible to penetrating trauma, blunt trauma. We'll learn next week it's also possible for uterus to rupture. That's an internal injury that goes with the obstetrics and childbirth chapter. We have 2 patients when we have a pregnant patient. Okay, file that away till next week. Well, no, we got to do a couple other things with it. In the last trimester of pregnancy, picture that enlarged pregnant abdomen with 6 or 8 pounds of little one in there and a liter or so of amniotic fluid, and that uterus is getting bigger and bigger. And if we position mom on her back to transport her, all of the contents of her uterus, as it has moved up out of the pelvis, can compress the inferior vena cava. What does that do? That's going to cause hypotension, because all of the venous blood that would normally move through from the lower extremities and our patient's lower body, all of that venous return that would normally come to the right atrium and then to the right ventricle, it gets dammed up. It's like putting a tourniquet on it that weighs down on the inferior vena cava, that stops the flow of venous blood. So we've lost preload, or a portion of our preload, and it's enough to cause hypotension. How in the heck do we treat that? We don't put them on their backs. We put them in the left lateral recumbent position. If they're on a spine board, we're going to have to tilt it up on the left side, and we're going to have to pack blankets or pillows or something behind that backboard and secure it so it's stable, but so mom is not on her back. She's on her left side. So that's how we manage that to avoid having hypotension from compressing the inferior vena cava. All right. External female organs. The times most often you're going to see in an adult female that you're going to see major trauma to the external female genitalia would be in sexual assault, and then sometimes in pregnancy. But that's, so we need to ask questions about that. And young girls climbing on things and fall and land with the straddle type injury, you can have a major tear of the labia or something like that, cause bleeding and pain. That's a touchy thing to assess. Have a parent with you and have your partner with you and a disinterested witness if possible. We don't want to be visualizing these areas of our patient without having our tail end covered, whether we're a male or female clinician. And our partner may not be good enough, and the parent, who could have a financial stake possibly through a lawsuit against our employer, they may not be exactly a disinterested witness. Am I saying that every call they're out to get you and you're always going to be accused of some sort of sexual assault of a female patient? No, I'm not saying that. Defend yourself against that 1 in 1,000 or 1 in 10,000, whatever it might be. Law enforcement or a firefighter, especially law enforcement, it seems that prosecutors tend to place more stock in what that law enforcement officer says happened while you were completing your visual examination. Unless there's external bleeding, we don't need to visualize or place any sort of dressing on our female patient's external genitalia. Generally, with males backing up to treatment, I had them hold direct pressure for me while I was doing my work, and even a 4-year-old boy will hang on to holding direct pressure if you're trying to stop external bleeding. We also need to use ice. Ice causes vasoconstriction, and that slows bleeding, and that's localized ice. Of course, we're not going to pack them in ice. We need to always be cognizant of keeping our patients warm when they're bleeding, right? Okay. Don't insert anything in the vagina. We don't pack anything in the vagina. We don't insert anything, including our fingers, in the vagina. No matter how much they're bleeding, we're going to apply those. Normally it's going to be a SurgiPad that, what is it, like 3-inch by 6-inch sterile dressing that we carry on the ambulance. Looks like a large Kotex, and we apply those. And as those become saturated, we apply another. Have to be professional, no matter how bad it looks. Don't let them see that in your eyes. We need to be reassuring. These are traumatic things. We need to provide prophecy. But hey, buddy, wait, you just said we need to have a cop there with us. We're going to provide privacy, but we also have to protect ourselves. That doesn't mean that law enforcement officer has to be down there in the middle of what we're doing. But if they have a vantage point so that they can see that we're not sexually assaulting that patient in some manner, we're going to be in a much better position over the long haul. Anytime you have a patient with injuries, with genitalia injuries, also get the name of whoever was your disinterested witness and document that, whether that's in your company's internal incident report or unusual occurrence report, whatever they call it. That's a great place to document it and have more of a narrative. And then down the road, if something comes up, everybody knows who to contact to help defend against a frivolous claim made against you, whether it's a criminal complaint against you or a suit for damages against your employer. You need to have documentation somewhere so that that disinterested witness can be found. Remember to look for blood in the underwear. What was the mechanism of injury? Was your patient raped with a kitchen knife that intruder in the home pulled out of the butcher block that held the knives and took that into the bedroom and used that to sadistically sexually assault your patient? By the way, that causes extensive bleeding and a patient who at least has a good chance of being in hemorrhagic shock. So assess for shock. If you can have a clinician of the same sex who does any visual inspection and applies any pads for to control external bleeding, do that. That's not always possible. We're looking for life threats, right? We're treating life threats. Don't skip over, just because it feels a little bit embarrassing, don't skip over visualizing at least the area, the underwear area of your patient that you've trauma stripped. With a patient with multi-systems trauma, a patient who's critical, trauma strip involves getting those underwear out of the way so you can look to see if there's any blood in the underwear, and that's just part of trauma strip. The other part is we keep blankets on our patients, we shield them, and we provide them privacy. You can cut up the back of the clothes to go through decap BTLS on your patient's back, and you could do that right beside the road when you're log rolling them onto a backboard, but you don't have to trauma strip the front right there in front of God and everybody and expose their genitalia. You just don't do that. Okay. Control any external bleeding. Transport decision. If you have, let's go back to fractured penis and it's distended, it's discolored, or you have someone who's been raped with a kitchen knife and there's bleeding, external bleeding from that trauma, a medical specialist is going to deal with that. A dermatologist isn't. Transport to the appropriate facility, and it's okay to, I think, provide rapid transport. I think the sooner those things are treated, the better. Okay. things. I'm just going to point out things that are extra or different about the patient assessment. Ask about hematuria, if they've noticed any blood in their urine. If so, how much? And then we still have to work through the entire sample history and the entire OPQ-RST. Secondary assessment, that hasn't changed. It's a full body scan, engaging DCAT BTLS. Vital signs, you know what to look for there. Vital signs that are consistent with shock need to get us up and scooting, and we need to be trying to kick tail on that platinum 10 and that golden period. We've covered all of this already today. Treatment of external genitalia, make the patient comfortable, use as possible, they should add. Use a sterile moist complex to cover any areas stripped of skin. Apply pressure with a dry sterile gauze dressing to control bleeding. If there is an object inserted in the urethra, oh golly, what have I seen? An ink pen shoved up a urethra. I've seen it several times. And I've heard even worse reports than the ones I've seen, but things shoved up a urethra. You never know what somebody is going to do. We don't manipulate them. We don't pull them out. We leave them there, and we're going to let somebody who writes MD or DO after their name deal with that. If you have any avulsed parts from the external male genitalia, we're going to treat that like any other amputated part. We're going to wrap it in sterile gauze. We're going to seal it in something like a Ziploc plastic bag. We're going to put that on ice and on like chemical cold pack and transport that to the hospital, avoiding any risk of causing frostbite to that tissue and killing it. Surgical reconstruction is possible. Not my war story, but one of my partners worked in Salt Lake City, Utah for quite a while. There was a guy had suffered from mental illness, and part of his deal was to go around and flash people, and he always felt guilty about it. And afterward, he walked into the middle of a packed McDonald's at lunch one day, dropped his drawers, pulled out a butcher knife, and sliced his penis off right there in front of the lunch crowd. And my partner said that they treated that like any other amputated part. They applied direct pressure to control the bleeding, and they took the guy's penis with them, and apparently it cured him of his desire to flash people, and they were able to surgically reattach that. As I said, urologists are amazing surgeons. Okay. Always, if you're gonna cut the clothing away and leave the part of the zipper that the shaft of the penis is zipped into, when you get your trauma shears out, explain before you get them out what you're going to cut and why. That you're going to cut the zipper around the zipper, not close to the tissue that's in there, and so that an expert can get that out. Don't whip out your scissors and think they're going to remain calm. Okay, straddle injuries can cause pelvic fractures in both sexes, but in females, it can cause penetrating wounds of the peritoneum. That's that area between the vagina, the vagina and the rectum. That is the perineum. Don't confuse that with the peritoneum. That's the perineum. It's highly vascular. It can bleed a lot if it's injured. Oh man, we keep going back to the male stuff. Okay, if there's trauma to the scrotum's open, uh, preserve the avulsed skin. So you have a flap of skin peeled up on the scrotum, and maybe you can even visualize a testicle in there. Let's wrap that area with a moist sterile complex. We're going to try to put that avulsed skin back in its as close as we can to the normal position, and then transport. It is possible to rupture a testicle with blunt force trauma or cause bleeding in the scrotum, and that can cause distension and pain. Put ice on it and transport them. Female external genitalia lacerations, treat with a moist sterile compress, localized pressure to control bleeding. If you put a bandage on, you could like try to create a diaper type bandage. I think that's going to be hard to do most of the time. Do not pack anything inside the vagina. Do not insert your fingers into the vagina. Any foreign objects, leave them in place. Okay. Rectal bleeding. Look for rectal bleeding, any blood in the undergarments. Could be caused by sexual assault, foreign bodies in the rectum, hemorrhoids, colitis, ulcers. Patient may require surgery. Assess for shock, treat for shock, transport. Sexual assault, generally it's going to be against women or children, sometimes against men. That's more common than you might think, but it is rare, and it can cause the same psychological problems that raping a child or a woman causes. Be compassionate. Assess to determine if there are any life-threatening injuries, and sometimes it's a violent sexual assault, and the sexual assault part is way down your list because you're dealing with multi-systems trauma, you're dealing with life threats, you're treating for shock. But if it's a sexual assault that doesn't involve life-threatening trauma, then take time to establish rapport, be empathetic, and utilize a same-sex clinician if possible. Do not examine genitalia unless obvious bleeding requires application of a dressing. That covers you. Shield that patient from onlookers. Where do you do that? In the privacy of their home or in the back of your truck. And like I said, it would help to have law enforcement's going to be investigating that thing anyway. If you could have an officer present with you, that's your disinterested person who is obviously going to document things well, and that could be your best friend 2 or 3 years down the road, or with a child 15 years, 30 years down the road. Okay, don't let your patient wash bathe, shower douche, urinate, or defecate until after the examination. They're going to feel dirty. This isn't their fault, but they feel dirty and they want to clean up, but that destroys evidence. And explain to them that it's normal. Don't say I understand, because you ain't there. Say it's normal to feel violated and feel like you need a shower to get the smell off of you. But we want to help you help them catch whoever did this to you, and preserving that evidence is the best way to do that. And it's not easy to do, but and law enforcement can help you convince them. If there's oral penetration, try not to let them eat, drink, brush your teeth, use mouthwash. Obviously, those are the first things that sexual assault victim would want to do. Uh, enzymes in saliva could damage DNA. Don't tell them that, but there may be enough DNA left there that it could help catch whoever sexually assaulted them. Be careful handling the clothes. Remember, we put those in paper bags and transport those to preserve that evidence. Okay, that's the end of that one. Let's take 5 minutes, and then that gives me 45 minutes to cover our other chapter.